swallowing evaluation, also known as a bedside swallowing evaluation, is a preliminary assessment of a patient's swallowing status. This helps the speech-language pathologist determine the need for an instrumental assessment, whether it be an MBS, which stands for Modified Barium Swallow, or a FEES, which stands for Fiber Optic Endoscopic Evaluation of Swallowing. The first step of the clinical swallow evaluation is for the speech-language pathologist to review the patient's case history and general medical condition. This will help determine whether or not the patient is able to continue on to swallowing trials, or if an instrumental exam is immediately warranted. Next, the speech-language pathologist will evaluate the patient's cognition, for example, his or her level of alertness and ability to follow directions. Finally, the SLP will examine the condition of the patient's oral cavity, most importantly, the patient's overall oral hygiene, as poor hygiene commonly contributes to aspiration pneumonia.
Step 2 is the oral mechanism examination. The items needed for an oral mechanism examination include gloves, but make sure the patient has no allergies to latex, otherwise use nitrile gloves. You will also need a tongue depressor and flashlight. If the speech-language pathologist chooses to perform cervical auscultation, a stethoscope is needed.
During the oral mechanism examination, the clinician will check for range of motion, strength, symmetry, and sensation of oral structures. Any weakness, asymmetry, or lack of sensation may indicate problems elsewhere in the swallowing mechanism that may contribute to dysphagia. The following video is an example of an oral mechanism exam performed on a volunteer patient.
Hi Stephanie, I'm Ashley. I'm the speech-language pathologist. We get the opportunity to work with you this afternoon. How are you?
Good.
Good. Great. Well, thanks for making it in this afternoon. I've heard you are having a little bit of trouble with swallowing, so we're going to try to get to the bottom of that today, and we're going to do your clinical evaluation, and we're going to begin with an oral mechanism exam. So the first thing I want you to do is just sit normally, and I'm just going to look at your face at rest to make sure that everything's symmetrical, and yep, it is. It looks great. All right. Okay, and now can I have you just lift your eyebrows for me and bring them back down? Great. Okay, and now I'm going to have you pucker your lips just like this. Alright, and can you smile for me really big now? Alright, and can you alternate between the pucker and smile? Great. Alright. Okay, next I'm going to have you put a bunch of air in your mouth and close your lips and try to hold it in just like this. Alright, you can release. And now what I want you to do is the same thing, but I'm just going to apply a little bit of pressure to your cheeks, and I want you to try to keep the air in and not let me push it out. Alright? Okay, go ahead. Alright, great. Okay, now can I have you open your jaw like this? And now close. And can you alternate between those two things? Perfect. Okay, and now can you move your jaw from side to side? Okay. Now what I'm going to do, so I'm just going to use one of these sticks, and I'm going to have you close your eyes. And I just want you to, I'm just going to lightly touch somewhere on your face, whether it be your forehead or your cheeks or your nose or your chin. And I just want you to just identify what area I'm touching with this, alright? Okay. Okay, so go ahead and close your eyes.
Forehead. Chin. Cheek. Chin. Nose. Cheek.
Great. Alright, great job. Go ahead and open your eyes. Okay. Next, I'm going to put my gloves on so then I can go ahead and take a look inside of your mouth a little bit. Okay. So I'm just going to have you open your mouth, and I'm just going to look a little bit around and look at your teeth and your gums and everything and at the top of your mouth. So if you could just open up, and I'll be really gentle. Great. Okay. Okay. Next, I would love for you to just stick your tongue out, and then I want you to touch your top lip with your tongue like this. Okay, and now the bottom lip. And can you alternate between the top and the bottom? Thank you. Okay, and what about if you can stick your tongue out and go side to side? Great. What about in and then back out? Okay. And can you lick your lips for me? From one side all the way up and then all the way up.
Like eating Oreos.
Yes. Alright. Now what we're going to do is I'm just going to look inside of your mouth and I'm just going to check out your oral cavity basically. So I've got my flashlight and I just want you to go, ah.
Ah.
Great, looks good. And then I'm going to take that tongue depressor and what I'm going to do is just put your tongue down so I can look at the very back of your mouth, alright?
Okay.
Okay. Go ahead and go, ah. Oh, great. That's good in there. Okay. And last time, I'm just going to have you go, ah, ah, ah. Ah, ah, ah. All right. Perfect. Okay, and then I'm just going to go ahead and look in again. I just want you to just open up wide, and I might feel around just a little bit to look at the sides of your cheeks. Okay. Alright, everything looks great. That wasn't so bad, was it?
No, it wasn't
No?
too bad.
Alright. Well, we're all finished with the oral mechanism exam, and we're going to move on now to the rest of the clinical evaluation, beginning with swallow trials. So, thank you so much.
Step 3. Swallow trials. For swallowing trials, the items needed are a spoon, cup, straw, a thickening agent, thin liquid, preferably water, nectar thick liquid, honey thick liquid, pudding or applesauce, a soft chewable like a cracker, and a hard chewable like a meat sandwich.
What to watch for in each step of the clinical swallow evaluation. First, the clinician will assess the skills required for successful feeding. These include the patient's ability to use utensils and transport food to the mouth successfully. The clinician will observe the patient's initiation and coordination of these movements. If a patient is unable to perform these steps successfully, the patient may have apraxia or ataxia. The clinician will also look for adequate oral closure while using utensils, straws, or cups. If the patient does not have adequate oral closure, the clinician may observe drooling. During the oral stage of the swallow, the clinician will look for symptoms of an insufficient oral mechanism. Bolus transfer problems may occur if there is lingual paresis or paralysis. Pocketing may result from buccal paresis or paralysis. Nasal regurgitation may occur if there is velopharyngeal insufficiency. Tongue pumping may indicate tongue or tongue base weakness and difficulty clearing the vallecula due to a neurologic disease. Finally, the clinician will look for timing of swallow initiation. One would expect to see a swallow to be initiated in about 1 second for liquids and about 2 to 3 seconds for solids. If the swallow is delayed, the client may have poor sensory awareness in the hypopharynx. During the pharyngeal stage of the swallow, the clinician will look for hyolaryngeal elevation excursion by palpating the client's throat. Poor hyolaryngeal elevation excursion would be caused by muscular weakness and may result in poor upper esophageal sphincter relaxation and opening. The clinician will perform cervical auscultations to listen to respiration and swallow coordination. Last, the clinician will count number of swallows per bolus. If the client swallows multiple times per bolus, there may be poor tongue base retraction, weak pharyngeal constriction, or insufficient cricopharyngeal opening.
When palpating a swallow, the index finger will be placed on the hyoid bone, the middle finger on the thyroid cartilage, the ring finger in the cricothyroid space, and the pinky on the sternal notch. After each trial, the clinician will look for signs and symptoms of penetration or aspiration by having the patient say ah, count, or engage in conversation and listen for wet vocal quality. The clinician should also look for any throat clearing, coughing, watery eyes, facial grimace, multiple swallows, and changes in respiratory status following the swallow trial. Aspiration may occur without these symptoms, and this is called silent aspiration. The following is a video demonstration of swallowing trials during a clinical swallow evaluation.
Alright, so we're going to move into the food trials of our clinical swallow examination. And so what we're going to do first is you're going to try just to swallow your saliva, and we call that a dry swallow. And while you do that, I'm going to put my hand on your throat just to make sure that everything's moving okay. Alright, so go ahead and try to swallow. Alright, now say ah. Ah. Alright, that sounded good. So let's do that 2 more times. Now say ah.
Ah.
And last time, go ahead. Now say ah.
Ah.
Good job. Nice. Now we're going to try doing the same thing where I put my hand on your throat when you swallow, but we're going to use some ice chips. And so what you're going to do is just take a small, maybe just a couple, and you're going to try not to chew them and just swallow them immediately. So I'll let you feed yourself.
Okay.
Now say ah.
Ah.
Nice job. Alright, so let's try that 2 more times.
Ah.
Okay, 1 more time for that. Good job. Okay, so we're done with that. So it seems like you're safe to move on to our thin liquid, and we're just going to use water today.
Okay.
And the first trial that we're going to do is you're just going to take a small spoonful of water and you're going to swallow that. And I'm going to have my hand on your throat for this one too.
Okay.
So go ahead when you're ready. Say ah.
Ah.
Good job. That sounded good. Let's try that 1 more time. And my hand's going to stay here. Good job. Okay, now let's try it 1 more time, but I'm going to use the stethoscope to hear how you're breathing while you swallow.
Okay.
And so go ahead and use the spoon and take another swallow, and this is just going to be here on the side of your throat. Good job. That sounded excellent. Okay. Now we're going to move on to something a little bit harder, and we're going to use a straw, but we're going to still swallow this water. And so I just want to have you take a little sip of this, and I'm going to have my hand on your throat again.
Okay.
You might want to lift it up, that might be easier. Alright, count.
1, 2, 3.
Okay, sounds good. Okay, try it again. And count.
1, 2, 3.
Awesome job. So you're doing pretty good for that. And I want you to take a couple, like 3 small sips, but in a row when you do that.
With the straw.
With the straw. And I'm going to put my hand on your throat again. Say ah.
Ah.
That was excellent. Now we're going to make it a little bit harder, and you're just going to take a sip out of the glass,
Okay.
just like you would regularly. My hand's going to be on your throat. So go ahead and take a small sip. Okay, say 1, 2, 3.
1, 2, 3.
Let's take another sip. And count.
1, 2, 3.
Sounded good. And I'm going to use this again, and I'm just going to listen to your breath sounds while you swallow with the glass. Alright, it's going to go on your throat. Alright, go ahead and take a small sip. Alright, sounded normal. Good job. Now let's try taking 3 consecutive small sips with the glass.
Okay.
My hand's going to be on your throat again. Alright. And say ah.
Ah.
Sounded good. How did it feel?
Good.
Everything feels good?
Yeah.
Okay. So now we're going to move on to something a little bit harder, and this is our
What is that?
This is our applesauce, and it's our soft, chewable food. So I'm going to give you a little bite.
Okay.
Alright, and actually you can feed yourself,
Okay.
and I'm going to have my hand on your throat again. Good job. How'd that feel?
Good.
It felt good? Okay, so let's try taking 2 more bites, and make this one a little bit larger than the last one.
This?
Yeah, that looks about right.
Okay.
Say ah. Okay. Now let's take... Alright, so let's try even a bigger trial with that one. So you can get that together. I'm going to put my hand on your throat with this last one. Alright, now say ah.
Ah.
Do you feel anything stuck in there, in your throat?
No.
No, it feels okay? Okay, good. So I think we can move on to our soft chewable, which is a cracker. And so I want you to take a bite of one of these, and I'm going to have my hand on your throat again. Say ah. How did that feel? Good. Okay. Alright, let's take another bite of that cracker. ah. All right, let's do one more bite and take maybe a little bit bigger bite this time, and we'll see how that does. Kind of dry, huh? All right, swallow it? Okay, good. All right. Feel okay? Nothing stuck?
Nope.
Okay, let me actually look inside of your mouth because it is kind of dry. Make sure that nothing is...
Try and take a sip.
Oh yeah, let me see if any food is in there. All right, so hold on real quick. You ready?
I guess, yeah.
All right, I'm just going to pull your cheek aside. Okay. Doesn't look like there's anything stuck in your buccal sulcus. So let's move on to a little bit harder trial. So we're going to take, this is our hard chewable, it's our dry bread with peanut butter on it. And so I'd like you just to take a small bite of that, and I'm going to have my hand on your throat again. Okay.
Can I take a sip of water?
Yeah.
Okay.
Yeah. Sorry. Okay, go ahead. You passed on those.
Okay.
Was that hard to get down? Did it get stuck in your throat? Okay, so let's try that again. So go ahead and take another small bite. Go ahead and take another swallow and see if that helps clear it. Just a dry swallow. Does that feel better with the second swallow? Okay, good. Yeah, that's a hard one with the dry. So let's do one more trial of that, and then we'll be all done. But you're doing a great job. So I'm going to have my hand on your throat for this last one. Okay, take one more swallow. I'd like you to say ah when you're ready. Ah. Okay, good. It sounds good. All right, so you did a great job. We're all done. Cool.
The patient in this video demonstrated normal, healthy swallowing. However, if a patient were to fail on thin liquids, the clinician would move to a nectar-thick liquid. If this patient were to fail on a nectar-thick liquid consistency, the clinician would then move to a honey-thick liquid consistency. It is important for the clinician to move through the hierarchy carefully. If the patient demonstrates too many signs and symptoms of aspiration, they must stop immediately. Limitations of the clinical swallow evaluation include subjectivity, varying sensitivity and specificity, limited information about physiology and anatomy of the swallow, and not possible to compare different swallowing techniques and strategies. If clinical signs of oropharyngeal dysphagia are observed during a clinical swallowing evaluation or risk factors are identified, then an instrumental swallowing evaluation may be recommended. For patients with signs and symptoms of oropharyngeal dysphagia, instrumental procedures can provide more sensitive and objective documentation of findings than the clinical examination. Information gleaned from these exams can be used to make appropriate referrals and to determine appropriate management and treatment of dysphagia. Indicators for an instrumental examination include the following. The patient's signs and symptoms are inconsistent with the findings on the clinical examination. There is a need to confirm a suspected medical diagnosis and/or assist in the determination of a differential medical diagnosis. Confirmation and/or differential diagnosis of the dysphagia is needed. There is either nutritional or pulmonary compromise and a question of whether the oropharyngeal dysphagia is contributing to these conditions. The safety and efficiency of the swallow remains a concern, and the patient is identified as a swallow rehab candidate, and specific information is needed to guide management and treatment. Indications for performing a modified barium swallow study include the following: to identify normal and abnormal anatomy and physiology of the swallow, to evaluate integrity of airway protection before, during, and after swallowing, to evaluate the effectiveness of postures, maneuvers, bolus modifications, and sensory enhancements in improving swallowing safety and efficiency, to determine appropriate therapeutic techniques for oral, pharyngeal, and/or laryngeal disorders. The patient will not tolerate fees, suspected oral stage problems, suspected esophageal problems, globus complaints, the need to identify which bolus propulsion force is weak, examples tongue versus laryngeal elevation, suspected aspiration during the swallow, and needing a better impression of the amount of aspiration. Indications for performing a fiber optic endoscopic evaluation of swallowing include the following. Position and fluoroscopy is problematic. Transport to the X-ray department is problematic. Severe dysphagia with very weak or potentially absent swallow reflux. Post-intubation and laryngeal trauma is suspected. The need to access fatigue over a meal. Need repeated exams in a short period of time. The patient could benefit from visual feedback to learn maneuvers. The patient has hypernasality or dysphonia, and the patient is having difficulty handling their secretions.
This concludes our video on a clinical swallow evaluation.
Thank you for participating in this educational experience.